So good morning, good afternoon, and good evening to you from here in the UK. Welcome to another Evening webinar. These webinars, and I see a lot of familiar names, so hi to everyone who's come back on. These webinars are focused on the topic of self-sovereign identity and digital credentials, and we run these webinars regularly to help you learn faster and build solutions more efficiently. You can find recordings of all the previous webinars we've done at evening.com/webinars, and there's some really good quality content in there for you to have a look through. If you're just learning about SSI, trying to work out how digital credentials work or how they can be used, have a look there and you'll find some fantastic stuff to look at. On our last webinar, we had Drummond Reed and Dr. Anne Kabukian, and they took us through the importance of what's called privacy by design, which was a fascinating session. And prior to that, we covered the significant movement towards industry support for BBS plus signature schemes. Today is going to be quite different. Today we've got a fantastic perspective for you. COVID's had a huge, massive effect on all of our lives, and lots of new initiatives have emerged from the shadow of COVID, and innovation in digital credentials has been catalyzed by the urgent need to solve very difficult problems. And we often hear lots about the bits and bytes of the technology and the cryptography and signature schemes and all that kind of thing, and not enough from end users who might want to use this capability. So that's where we're going today. And today we've got someone unique and in a class of one to inform and educate you. Really delighted to welcome Dr. Manreet Nijjar. He is unique in that he is a practicing infectious diseases doctor or consultant, to use the right terminology here in the UK, in the UK National Health Service. And he's been on the front line of the COVID response in London in one of the hardest hit hospitals, while simultaneously being an expert in the implementation of and the end user needs for digital credentials and self-sovereign identity. So I don't think there's anyone else who's been doing the same thing. Manny, do you just want to say hello to everyone?
Yeah, thanks, Andy. Thanks to the Evening team for hosting me. I'm really looking forward to this session and to share my lessons.
Yep, great to have you here, Manny. So just before we get started, please note, as usual, we're recording this webinar, and we put the recording up on evening.com/webinars afterwards. So you'll be able to review it again there or share that and let other people know about it. Also, as per usual, please put any questions you've got into the Zoom Q&A. There's no such thing as a bad question, and we usually get loads of them. So any questions you've got put in the Zoom Q&A, you'll see the little Q&A button at the bottom. Behind the scenes, Alex, who's our webinar guru, gathers all of these questions together, and we'll cover as many of them as possible after the formal presentation from Manny. Fire the questions into the Zoom Q&A, please. So on the agenda today, really just a quick summary of what we're going to have today. Manny's going to bring in this physician's viewpoint for SSI with real first-hand experience of the tech itself and the opportunities for and the questions about its wider implementation. So without further ado, Manny, we'll just do the screen share swap over thing, and we can go on video and drop the slides off. So over to you.
Thank you. So thank you everyone for attending this webinar. Again, I'd like just to say thank you to Evening to actually give me the opportunity to share this. The last 18 months have been a roller coaster. So I have 3 roles or 3 hats, which I consider being one hat. But like any good doctor, I would declare my conflicts of interest, but I think they're all joint interests. So I'm a consultant physician in infectious diseases and acute medicine at Whipps Cross Hospital in East London. I am the associate clinical lead for COVID-19 response and have led the hospital through the last year and the 2 waves we've had. I'm also co-founder of Truu, which is a digital staff passport and credentialing and verification platform for healthcare workers and organisations. That was started 6 years ago, and a fellow on the NHS England Clinical Entrepreneur programme, which is run by Professor Tony Young, where they take frontline staff and they get them to innovate and trying to spin off businesses to actually solve problems from the front line. And I'm grateful for his support over the last 5 years as well. So I'll start with a quote. The physician must have two special objects in view with regard to disease, namely to do good or to do no harm. This was written by Hippocrates almost 2,500 years ago, and ironically in a book called Epidemics. And this has really stuck with medicine and the healthcare profession. And out of that's come these principles of medical ethics. And they're really important. Autonomy, which is the respect for a patient's right to self-determination. Beneficence, the duty to do good. Non-maleficence, the duty to do no harm. And justice, to treat all people equally and equitably for the benefit of society. So my presentation today is going to be interwoven with these medical ethics and always pointing back and directing me back to these points and how I've thought as a clinician, but also of a founder of a company and a business, how to do business in this new era to solve problems the right way. It's because of these, the healthcare professionals are considered the most trusted professionals across society. So this is an ISO poll, which was done in November 2020. It's the most recent. And as you can see, nurses and doctors are the most trusted profession. But with that comes a responsibility. And I think being grounded in those biomedical ethics gives us this, and it's this circular thing, right? And we do this by learning, educating, collaborating, putting our hands up when we do something wrong, trying to be transparent, and not saying we're right all the time when we're wrong. I think this has been quite important for the last 6 years, and the success we kind of had in delivering a digital staff passport solution or evolving one. So what's been happening? So my journey started in 2015, and it was a personal pain. I was a medical registrar, so training to become an infectious diseases specialist in a 1,000-bedded hospital in the south coast of the UK. I was doing a particular set of nights, so doing 14-hour nights, covering about 500 beds, including a high dependency bed, the most senior medical clinician on site, because consultants are off site. I'm glad that happened now, so although during COVID I had to go in. My problem was I kept getting called by a temporary agency doctor every night. Both myself and the nursing staff had concerns about the level of skills, the qualifications, the decisions he was making. I tried to feed that back to the hospital administrators and say, look, I don't know this guy's skills or qualifications. He's a danger. To what response I was told, we've got shortages and we need to fill the gap. I, however, had to wait 2 years to get into my training post, and I knew this local agent doctor was getting paid a lot more. I felt it was a broken system, and at that point, I was almost about to quit my career in medicine. But I then decided to do something about it. I wanted to figure out how I could instantly verify an individual so we can make patients safe. So 2016, I think, Andy, you might remember this. So I'd got the problem, I was still trying to refine it, trying to figure it out. And then I had the problem, and then I started saying, well, I need a digital identity solution, right? How can I verify someone using technology? And at the same time, decentralized identity, self-sovereign identity was emerging. Where it's serendipity or timing, I had the honor to be at the launch of the Sovereign Network with, I would say, the giants of the industry, people who led it, the likes of Timothy Ruff, Bill Windley, Peter Simpson, Doc Searls. And that was the first moment to say, here's my problem, and I'm looking at this emergent technology to solve it. Not saying, here's technology, what problems can we solve? Because it's always been about focusing on the problem to hand. So 2017, the team, myself, my co-founder Henry, and another doctor, kind of really went into distilling the problem. And it was three main aspects. Primarily, number one, patient safety. How do we verify the identity of and skills of a temporary or permanent clinical staff member? Number two, the burden on clinical staff ourselves. So Henry and I were both in training. We rotated sometimes every 3, 4, 6 months, having to give repeated amounts of paperwork, take 3 days of annual leave, go to one place, scan our documents, a delay in start. It was just a huge administration burden to us. Really frustrating. Add to that, we then figured, well, if we can digitize something and have a credential or our identity, that's the same as a username and password. And we knew the problems with multiple usernames and passwords, always having to change them, losing them, not remembering them, having multiple systems. And we thought, well, actually, if we have something to say who you are and you can do this, how powerful would that be? Not just from our point of view, but from a patient safety point of view, from a privacy and confidentiality point of view, which I'll come upon later when we talk about medical ethics and law and how SSI applies to them. And then from an organizational point of view, hospitals, for example, how do they reduce the risks and operational inefficiencies? Failure of checks, and actually the time and cost for repeated onboarding of healthcare staff. Delay of staff being there, being short-staffed, has a direct impact on patient care. So 2018, the great team from Blackpool Teaching Hospital, who've been immense over the last 3 years within the NHS, really pushing this forward. I think they went out to Tech UK to look at a similar problem about how would you verify a locum agency doctor turning up to an A&E. And I think they were working with Accenture, IBM, Oracle, and Microsoft, and they heard about us, they approached us, and we've always been open and collaborative, and we joined the team. And we did a lot of work. So this journey has not just come overnight. This has been 5 years of hard work, doing a lot. So we did some user need analysis. We had an advantage because Henry and I had our own from that side of point of view, but also the HR departments that we interact with and the flows of all information. And equally, engaging with all stakeholders. NHS England, the medical director from a safety point of view, Health Education England, because they know as we rotate and training, that junior doctors on their review said this is one thing they're fed up with, and it's this administration burden, and we know it's having a direct impact on numbers of doctors leaving the NHS to do other things. Working also with the GMC, NHS Digital, and all those other organisations you can see. So we spent 9 months doing that, and we took one of the most difficult but transferable use cases, and that was selected for a POC. And what I want to say here is it was a success with so many different organisations working together to try and solve a complex problem. 2019 came along. We carried on. The alpha was a success, the discovery was a success. There was a clear need, everyone knew it, the technology was emerging, and we thought, okay, what's that second step? Can we try and do the logging? So this is me at Blackpool Teaching Hospital again, in their A&E. And we worked with the GMC. So the GMC issued a credential, which was similar to that. It was a license to practice. That was then verified by Blackpool Teaching Hospital saying, I'm a doctor, I'm qualified, I'm registered to practice. They did a check and they issued a login credential. And then we did a bridge into their existing clinical systems. Then 2020, COVID-19. So this is, I think, the second time I'm really talking about this, so I might get a bit emotional. It's been quite traumatic here. I'll bring back the ethics, right? These 4 things have literally for the last year and a half, every day, have actually got me through sometimes. Especially difficult when delivering care to patients, when the times are very challenging, resources, people scared, having to lead. I would say it was the hardest thing that I've definitely done as a doctor and almost certainly as a human. I recognise it was not only the disease itself, it's impacted people's mental health and well-being directly and indirectly through restrictions, delays, treatments of other illnesses, but also economically and societally. I'm a co-founder of a business. I understand that. I understand having to pay people's wages and understanding that. I get it. I'm in a unique position. But it's also highlighted the widening inequalities we have. We knew that already existed, but outcomes depending on your race or your socioeconomic background. And that links back to that ethic of justice, equity and equality for when we deliver something. So this was me, I think March last year. So I set up the first ward. I was doing 17, 18 hour days. Being at 6, wouldn't leave till 11. Those are the side rooms, that's the first ward. And it was just, you were treating your colleagues, the nurses you were working with. We lost a doctor, sadly, that we worked with because we couldn't, issues with PPE. We ran out of oxygen, we had to close our hospital. And then you'd come home and you'd want to unwind, you know, see what's going on in the tech space. And then go on LinkedIn and you'd see people talking about immunity passports, sensitivity, specificity of COVID tests, how proposed solutions solve problems. And there's me, and it's taking 4 days to get a test result back, or understanding the sensitivities, specificities are low because the test is evolving, understanding a disease that we're all learning about. I suppose most of these people are well-intentioned. I'm guessing some commercially driven, but like many things over the last year, not very well informed. I wasn't very well informed a year ago. I was learning, and I'm a specialist in the field. I know how infectious diseases work. And I kind of want to use this as an opportunity to also educate, right? So we can work together to create the best solution. So during that time, what did we do? So my colleagues and I, we got recognised nationally during the first wave. We had the problem. We knew we were getting, the test results were delayed, very limited. So we came up with a scoring system based on blood results. And then we used technology the right way, privacy preserving, but helping us kind of risk stratify who we thought had COVID and not right at the beginning. So we were identified as one of the highest performing trusts. and myself and Dr. Shreen Thomas and Dr. Douglas Figg were recognised for this scoring system. That has shown that we've got one of the lowest nosocomial spreads or infection in hospital because of what we implemented and learned. Because knowing the problem, understanding the problem, being an expert in the field, delivering it the right way. And the reality was there was no one else there, and we were just left to do it. And that's what came out. I'm really proud of my team for that. We also then took an opportunity to look at antibody research. And so this will be interested of those who want to do immunity passports. I don't know what we found out we followed up about 450 healthcare workers, and we checked their antibodies, and that's their IgG, which is the one that's meant to stay. And we found a third lost it after 3 months. But that doesn't mean they're not immune. We don't know what it means at the moment because there's multiple pathways of immunity, cellular, antibody-wise, and this is the kind of education and understanding you might not understand if you don't understand infectious diseases, right? Why? This might not be the right thing to do. One interesting finding we did find from this small study was actually people who did worse had a stronger immune response, and that kind of fits with the disease because it's the virus that triggers the immune response and the complications of them. And it's quite a phasic disease, which is over 3 weeks. So the first week is your initial infection replication, and your second to third weeks is when you get more severe illness and when your immune system goes in overdrive. We didn't just do that, we also looked at digital credentials. This is my co-founder Henry, James Brogan, who's a medical student in America, and Christian Rose, who's an associate professor at Stanford. And we just published, we pushed out this submission for publication in the medical journals. What we realized was from our experiences across the pond and here, it was very difficult for healthcare systems to be flexible and agile, to keep that standard of getting someone deployed quickly, but having that high level of trust, right? So we explain in this paper, this is a critical moment for a shift from physical to digital credentials. We need to do it the right way and be prepared for the future, but also bring efficiencies into our current processes, right? And not just in the physical world. We are moving to a digital world. The expansion of telehealth, 75% of consultations in primary care were done remotely. Where is the trust? How do you know that doctor is that doctor? We can do better than just username and password. Anyone can get in there. We know there's cases of fraudulent actors, right? So if you implement this infrastructure the right way, it can have so many benefits. And also, that last sentence, enhanced information exchange, access. You can save a lot of interoperability if you understand access and consented and audited access. And that is really important on confidentiality and privacy, which currently in electronic health records, we don't audit well. So people can access people's information, whereas previously no one could just turn up to a ward and look at someone's paper file, they'd be challenged. So these are important considerations as we design systems. NHS England, the People Directorate Improvement, have been doing some great work. This is all publicly available information on this website. They've created an interim COVID-19 digital staff passport and beta testing. I checked on that website link, I think it's 84 NHS organisations. Also, our work with all these people I've mentioned to now has led to this, right? The Department of Health and Social Care recognise our work, right? The NHS is developing identity and access management capabilities to let staff log in with credentials. NHS HE, all the people we worked out with Blackpool in 2018 and 2019. All the problems that I have said that we started on our journey, right? This is in their policy, right? Empowering frontline staff by reducing administration bureaucracy. So hopefully I can go from this, having all my credentials, having to check them multiple times, to this, the solution we've created, and all focused on the user. How can I orchestrate what a doctor needs or a nurse needs when she transfers? A digital staff passport, where I can hold my information, I can log in, I can sign up to a course. You know, I can keep connected with my GMC. What are my requirements? And from a hospital's point of view, seamlessly onboarding people, taking 3 minutes as opposed to three months in some cases, saving those efficiencies, bringing a high level of trust into a system that is based on trust. So that's me on digital staff passports. Vaccine passports, I kind of find myself in a very unique position, obviously being an infectious diseases physician and understanding this technology. I would say there's different ways to meet a requirement, okay, and they can be ethically good for individuals all the way to unethically bad for individuals. And I think that's the concerns with vaccine passports. I think everyone can agree depending on what your need is and understanding that it's a spectrum. However, if we do not understand the exact problem we are trying to solve, that whole first sentence becomes irrelevant, okay? And even worse, we have intended or unintended negative societal consequences. So this is where, back to the ethics, non-maleficence comes in, right? What is the impact? What are we thinking about? Is this good for us? Is this bad? I don't know, but we need to ask these questions. Okay. Do we really need a COVID vaccine passport? Whether this is paper-based or digital, right? Now, I'm an infectious diseases specialist. I think it's about context, okay? Would it be more beneficial than not, okay? Once you've answered that context in that specific use case, then what technical principles and implementations considerations are needed to be met to make sure you deliver this solution that complies with the medical ethics and laws that we have been living by for 2,500 years, that has given us trust as a profession. Not a technology-driven solution which might not have done impact analysis, which might be detrimental just to our generation, future generations, because after all, this is personal health information and therefore needs to be treated as such. So there's loads of initiatives out there. What are they really trying to solve? The IATA initiative with the testing is something I agree with. I think knowing and testing someone is amazing, right? Because that gives you, from an infectious diseases point of view, you can start understanding sensitivities and specificities, but even taking into account, that gives you an idea of the prevalence, the background prevalence and the context, right? Okay? But to understand what you are doing, you need a basic understanding of this infectious disease, right? And what tools we currently have to deal with it and address the assumptions. That I think the most important thing is some of those assumptions may change and are yet unknown, such as the dynamic nature of the pandemic. So it's that dynamic nature that we find very difficult to deal with as humans, and that uncertainty. But how do we develop systems that allow us to address those instead of being very rigid and creating an unintended consequence that might lead to exclusion, or make the assumption if you're vaccinated you can't get an infection, or that means if I have a vaccine I can go to my nice holiday to a poor country where they don't have the healthcare systems and I'm fine and they let me in and I spread it, right? These are considerations. And some of this information will be out there. We know there's reduced transmission when you have vaccines, but it doesn't mean you don't get the infection. We don't know what the impact of variants are going to be. We just don't know some of these things, right? Instead of pushing it, whereas you can test everyone, that's a great idea, right? And I'm not I'm not arguing for or against. I just think the thought needs to be very balanced, and people need to think more at a global level as opposed to an individual. And that's always the problem with pandemics. It's individual health against population health, and it's individual rights against population rights. And those are where the points of debate have to happen. But as technologists, I think the way technology is implemented can influence policymakers, because policymakers also need to understand and learn, and we all need to. I don't know all the answers. These are just questions I'm putting out there. This is just a very simple thing about education. I kind of said it. So the disease itself is called COVID-19. You are infected with SARS-CoV-2. That is the virus. Okay. If you're infected, you can be. If you're not infected, you have no disease. If you get infected, you could have no illness, and that could be because you just don't show any signs, or you might be in the early phases of replication, pre-symptomatic, and go on to development. Mild, moderate, severe, and critical illnesses are how they're defined globally, and you're infectious throughout all of them. So the challenge comes is those people who are really asymptomatic. We know the majority of younger people can be that, although as we are learning, variants around the world are now showing more severe disease, such as in Brazil, and the tragedy that is happening in India at the moment, which is not helping us as a world, because the more every time it transmits, there's every chance for it to mutate. And this is just slightly off topic, but this is why we need to think about it, right? The Red Crosses are the countries that don't want to release the patents on the vaccines. Okay? Those are the countries that everyone's getting vaccinated in. But we're a world, right? This is a global problem. The virus knows no borders. You can argue and say Australia and New Zealand did well, but the demographic is small, they had tighter controls, they're more dispersed, they're not as dense populations. But we need to look after each other, because we're just going to end up in a cycle, which we could end. This will eventually peter out, but there's going to be long-term consequences. It's what decisions we make as a society, and what ethics are they based on. So when people talk to vaccination passports, I've heard people talk to me about yellow fever, and I agree. Yellow fever is a perfect use case for it. It's a disease. I understand the disease, obviously. It's an endemic disease. It's only in America, South America, and Africa, in a certain region. Its vector is a fly. It's not a respiratory. So mode of transmission is different. That's why we don't want it to move anywhere else, because we've got it controlled and contained in a certain area, and it's passed in international health law, right? And that's why you need to quarantine, right? But that took us years to get to that stage. And then we realized, hey, you only need one vaccine. You don't need a booster at 10 years. So we learned about that. So COVID is totally different. You can't use that, because you need to understand the disease, because everything is contextual and relative. But this would be a brilliant use case to do it. But again, to say you've had a vaccine, right? Excellent, because we already have that paper. But again, it has to be about equality and rights. So the paper's doing a fine job, but actually, because COVID is so global, it's very different. So my take on this is not about digital vaccine passports. I think it's greater and more important. I think this is about personal health information. And I think how systems of technology is implemented in healthcare and what ethical framework are they held to is something really important, and something I think I'm going to move towards, working towards, is if a drug is developed, they go through phase trials, they have post-surveillance studies. How we implement technology is going to have an impact on people's healthcare. Digital therapeutics, we need this surveillance. We need to understand that. They all should go back to those medical ethics. That's how the system should be developed. So this is something I'm proposing. I started working on this. I shared this at IIW, the Internet Identity Workshop, last week. I have on the left side the 4 basic medical ethics that I've been talking about: autonomy, beneficence, non-beneficence, and justice. That's UK medical law, which actually enables those ethics to be in action. So for autonomy, consent, confidentiality, privacy, access to records for an individual, negligence law, if we do no good, and if we do harm, we've got criminal law, negligence law regulation, and anti-discrimination law for justice. Okay? Now, the 12 principles of SSI fit into this when we design the system in healthcare and healthcare technology, and maybe across society now, because the bounds of healthcare information are not just staying within healthcare, they're going to travel as it looks like. But autonomy will fit with the interoperability, control and agency over my information, privacy and minimal disclosure of what I want to say. If my HIV patient doesn't want to say anything or do anything or share it. Portability, I can share, I can hold and control my records. I want to make sure it's secure, okay? That's true autonomy. To do good, to benefit, that information has to be authentic and viable, or as much as we know, what source has that come from? Is that trusted? Or is it auditable so we can figure it out, right? It has to be transparent, right? What was the process around this? How was that information given? What is the veracity of that information? Same for non-malignant. And justice. You have to create systems where everyone is equal and can participate, and it isn't detrimental to a certain part of society, okay? And usability, accessibility, consistency. Are we there yet? I don't think we're there, but I think we made huge steps over the last 5 years. I say to people, we were going from 2 to 3. I think we've got to 2.5, right? We're 2.1. I mean, that's how we get there. We learn, we refine, we work problems out, we understand. SSI in the future of healthcare. I had the privilege to write this chapter. I think this was before COVID, and it's just still under preprint digital review at the moment. So it should be, I think Drummond Reed told me it should be done by the end of April, maybe May. So I've been looking at this. I've been looking at decentralized digital identity in healthcare, and I've been future kind of casting specifically in terms of the foundations of the new era of trusted relationships between individuals, organizations, and clinical things. And I think this kind of, I'm going to go to the next diagram, which is a bit busy, but what the work we were doing at Truu is the specialist doctor and the GP are in the middle, and every line is a peer-to-peer connection, and that information flow has veracity, auditability through verifiable credentials, right? And now you start putting the patient in the middle, so you could say, I get issued something, or I will share this, and this is consent. I think that is where we're trying to get to, right? And it could also be very powerful because we have all this siloed information already. And this could be the key to bridging that, right? He has access to this information so you can read it. You might always be able to write, but as we move. But one thing I've always said, we're on a spectrum, right? So sometimes a centralized solution might work. Others are decentralized, and I think in healthcare a lot. And that depends on the individual, understanding the individual, their capacity, their understanding what they want, what they need. Are they fully informed? Like anything I do, informed consent, that is really important. And I think that's it. And I think I'll leave you with a quote from Albert Einstein. My details are at the bottom. I'm more than happy to be contacted, open to collaborate, want to learn, want to share my experiences. And I'm happy to answer. I'll hand over to Andy. I'm happy to answer any questions. I'll try and come off with you.
That's awesome, Manny. Thanks very much. Yeah, very powerful stuff. And now we can see you now as well. So.
Yeah, I know. I just saw that now.
Excellent, thank you. Yeah, like I say, really powerful stuff, and enlightening to hear of your experience, which is, I think, unique amongst clinicians and SSI people as well. So that combination is really interesting. As you can imagine, we've had a whole bunch of questions come flying in, and just picked out a few of them here. So let's revisit the vaccination credential situation again, shall we? Because you covered it with some sort of detail, but maybe we can go up a bit of a level, right? Because you mentioned the IATA travel pass, there's the EU green certificate scheme, there's a whole bunch of other things that are combining test results and vaccination credentials and proof of whether you've had COVID before and recovered. You seem to be saying that the only, or the most reliable thing that is actually useful is a test result, a recent test result at the moment. Is that right?
Yes, I say context, right? So the data shows that vaccination reduced transmission. So in 6 months' time, when we know the vaccination studies say, hey, you've got immunity lifelong, I might turn around and go, that's a good thing to do, right? But what we know in the world is the testing is really good because that helps us at a public health level, that gives us reassurance, and that can help not just the country you're leaving but going to, right? And so that's like more of a global kind of, it's more of a responsible way, right? And that's the assumptions that people are making at the moment, right? There's 1 billion people in India, and every single time that transmits, and if half the people are having vaccination, there might be a vaccination pressure. There might be an escape mutant, right? So you then might be 3-4 weeks behind and just saying, oh, hey, you're vaccinated, hey, you're off, and that might change as the data comes out, right? And it's not, if you don't understand infectious diseases and immunity, and then you try and put a technical solution, like the principles are brilliant, but the actual problem you're trying to solve, it doesn't fit, right? There's a disconnect. Whereas the test, really important, which I would say test. Outbreak medicine, always test, right? Test. Like that is what I would say, right?
Yeah.
I know that comes with pain. Eventually, hopefully, if like viruses have been with us for millions of years, we'll absorb it, right? This is a real big inconvenience because we live in a hyper-convenience world. So contextualize it. We went from 20 years ago, I can get anything off this thing right a second ago, whereas, that's contextualization of what we are as beings and humans. I think that needs to be called out.
And the world's a lot more connected now as well, so hence the massive spread and the very rapid spread as well, right?
Yeah, and that's the thing, right? And what do you want to do, right? How do we think about the problem? Do you think a problem at a very local level and just care about, hey, I'll just lock down, you could just say, I can just lock down my house and no one gets it, or do you think at that global level, and you're just stopping at different levels, right? Whereas doesn't know that.
Yeah. Where do you put the barrier up? Yeah. So Lucas Svek, hi Lucas, was asked for a bit more detail on this, and saying, well, how does it compare to a more centralized solution, right? Now, we covered the IATA travel pass, in which there's been global interest. We had a webinar on that a few weeks back with IATA. So maybe, Alex, you can drop a link to that webinar in the chat. What they're doing with IATA, they're trying to solve the problem of opening up the airline industry and people traveling around, and they're using a test, credential that gives you your test status that confirms then that you're okay to fly for the entry requirements for another country. The alternative to giving people a digital credential would be to put all of the data in some massive global database, I guess, that all the airlines and all the labs and all the airports and all the border forces would have access to. I mean, what's your view on that kind of thing, Manny? Apart from it probably being illegal in quite a few countries.
So I don't know if you saw that, that the table I worked on the principles of SSI, and so that goes against. So this is a really important point. So this is where public health and individual health kind of conflict, and how you interpret those medical ethics. But by law, your privacy and confidentiality is what's the incentive mechanism on what you're trying to do, right? Should be minimal disclosure to say you can travel if you want, right? And the individual to have that right. I'm not allowed to access anyone's health information as a doctor within my hospital unless I have a right to.
Yeah.
But that is the blanket. So why should anyone know anything about me and my health?
An airline that doesn't need to treat you for anything.
And why have it as a health? Even if I'm as a health professional, right? I can't do it unless I have direct care or impact to that individual.
Yeah. And in fact, IATA have gone down this digital credential route precisely to give people the data that they can then, they're in control of sharing. The last thing they want is some massive central database for that reason. But there was a comment actually made by Brad, hi Brad, saying, I think we need to stop using the language proof of immunity. I think you were really careful about that, weren't you? Because, and this is one of the subtleties that people who aren't as familiar with this this kind of world might come up with, saying, oh yeah, proof of immunity. Brad's saying stop using that. You didn't use it, I don't think, but it just...
No, I saw LinkedIn posts of people talking about proof of immunity and it doesn't exist.
Exactly, yeah.
And it's like, what you're trying to push... In 5 years' time, you might be able to use COVID proof of immunity once we have the information.
Yeah.
I did a study on antibodies. Specifically, we did that research showing a third of people lose their antibodies. So people correlate antibodies to immunity, which actually doesn't make sense because we've got two ways to be immune. We've got cellular and we've got humoral. And it's just understanding all that information and applying it.
Yeah. So, you have proof that you've had a vaccine, and then somebody else can interpret whether they're happy with that to let you do something, but it's only proof you've had the vaccine. It doesn't.
Yeah, again, you don't get the infection, right? Yeah, that's your policy, right? And that, I think, is very important that health experts, technologists, policymakers work together. And I'm not going to say anything controversial, but we understand there's political motivations, economical motivations. We want to commercially get everything started again, but safely, because if you make a mistake here, you might delay it, right? It's really important we do this, right? Because it's people's livelihoods, because people aren't getting paid, right? But everything is interrelated, and that's how we need to understand it.
Yeah. Let's just come off the travel use case bit, because I feel like we talked about it on these webinars till we're blue in the face. So let's come on to this question from Marty, who says, is there any data that speaks to the cost benefits realized by healthcare systems that leverage verifiable credentials, or any anecdotal examples? So probably going back to your first use case of how do you know the doctor or the nurse is a doctor or a nurse?
So the data we've looked at independently, and I don't have the link, but I'm sure I can share it with you, about the report that was done. Is I think £3 billion nationally could be potentially, globally could potentially be saved, and that's just for checks. We also know the CME kind of continuing medical education is a huge market globally in multi-billions. We know it's 100,000 junior doctor days a year. So that's 60,000 doctors in training. 100,000 is taken away. So that's almost 800,000, maybe 1 million encounters, which then has an impact.
Just say that again. This is taken away how? Why is that?
The physical going in with your documents.
So document checks for junior doctors.
Yeah, it's 100,000 doctor days a year.
100,000 doctor days from just standing around waiting for someone to photocopy your medical degree and put it in a filing cabinet.
And then obviously when you're off work, someone has to fill your shift, and they sometimes don't get it. And so there's loads of associated, and that's why I think the Department of Health recognise that, right? That's why they've come out with that paper, because they understand what cost saving and it would have an efficiency.
And from like a use case perspective, what people often don't realise with the National Health Service is lots of trusts with their own systems, and if you're a doctor working at one hospital, you go to another, they need to onboard you, don't they? It's not just, okay, I like, happy days, I'm working for one big happy family. It's a separate organisation essentially, right?
Yeah, it's just they're all different organisations with an overarching mandate, and they have their own budgets and their own accountability, own governance, so their own liabilities. So everything is their kind of responsibility.
Yeah. So from an SSI perspective, where you've got this is a lovely use case, because SSI is really well suited to where you've got lots of disconnected silos, and the person, in this case a doctor or a medical professional nurse, is carrying the data from one place to another for the hospitals, right? So they're porting it with them, and it can be verified at the other end. So that's the kind of big step forward, if you like, isn't it?
Yeah, and I've said this, I don't know if I said to you, Andy, I think you can kind of make the individual that moves a lot the interoperable piece, instead of trying to all these systems, like trying to, that can be the first bit, right? Because then once you have that once you solve that physical pain point, adoption for us, because we would all, every doctor and nurse I've spoken to, I've shown, would say, when's that coming out? When can I have it? Then you then bridge that to actually we can then do access information.
I was going to ask you that. Sorry, John. I was going to ask you that very question. Some chap called Phil Graham has asked this question. We know Phil very well. Hi, Phil. Thanks very much for asking this one, Phil. Actually, what have you learned from the digital staff passport work in the NHS, from things like information governance, technology, and trust? You've been very close to it from the doctor side as well.
Was that specifically on those 3 points to be asked, or just generally?
Those 3 points Phil has asked. What have you learned from the digital staff passport work in the NHS and relating to information governance, tech, and trust?
Okay, so I think I'll start with trust. Obviously, the trust mechanisms. I think we now have technology that can enable trust, but we've still got the human trust. Okay, and it's how we bridge them and use them together. I think from the information governance point of view, I think look, we're not totally there, but we're a lot better than where we were, where auditability and traceability of information, flow, consent, GDPR, right? If I'm consenting for my information to be shared, I know exactly where it's going. There's a record. And what was the third one? Sorry.
Technology. I think there's probably a bit more in information governance bit actually, because you spend a lot of work spend a lot of time and effort translating existing policies for physical document handling into the sort of digital approach, digital credential approach, right?
Yeah, so you have those policies that you can enable with the technology, but actually the technology also gives you another enabler, right? Because you've got that cryptographic trust, right? Which kind of might get around some of those, right? And it's leaning and educating everyone about that. But obviously it's steps, right? Because it's sometimes too much of a big leap to do that. So you go through the process, but ultimately, remember, if we're moving to a world where we want to be in a more efficient system and the individual's in control, and I'm not saying I love the NHS, but I'm not owned by the NHS. I have a relationship with the GMC. If I wanted to do private practice, I have a relationship with a private provider. If I want to go to telehealth, I have and that's where those organizations all have their role in there. But it's actually, I think the biggest thing I've learned, it's about the user. It's about solving the solution for the user and listening to the user. And the user will come up with a solution. I'm not just saying that because, hey, whatever. I've always been open and collaborative, and I want this to succeed. But I just innately know stuff, and working with technology providers, you to help me, and we work together to do the solution, the right solution. You're not going to go and deliver a doctor's passport because you guys don't know anything about it, but you will help give us the
exactly. Exactly.
That's the understanding, I would say, that needs to be understood, right? At all.
Well, if it's got to be attractive and useful for medical staff to use, or staff members to use, right? So I think we've got a really nice SSI use case with lots of silos, not only within the NHS, but the GMC is another one, and private practice and university. And in fact, Mark Packham has said, how can you bring in things like diplomas, degree awards, GMC documents, that kind of thing, into the whole ecosystem?
Do you want? Yeah, so we're already working on that. Because obviously we go through. It's my own journey, right? So I had to show my medical degree, or my university had to show the GMC, and there was already established relationships with all the medical schools, and so this ecosystem is already created. So that's where you do it, right? That's the ecosystem we create. How that journey is going to be useful, and people on board at various points, and we understand that because Henry and I have been through it multiple times, and we've been testing it with our colleagues, and they tell us what they want because we work with them every day, and so they think this is what we need, and this is what we want, and we're like, okay, well, listen, we'll go and try and build this for you.
Yeah, I guess one of the good things about a digital credential approach is that once you've got the platform in place that can issue or verify credentials, it doesn't matter. You can add more credentials, right? So you can add additional credentials and expand it, you don't need to change the underlying platform under the skin. So if the GMC wanted to issue credentials, the NHS could accept those, and they've already got the engine to do it.
No, I agree, and I think also, Andy, I just want to kind of be clear to everyone is we started this 5-6 years ago, right? And we've come a long way, right? And there's been brilliant stuff that's happened, right? But we're still learning, right? We know there's things that we still need to deliver, and we're realistic with people, and to bring them on the journey and go, look, there are certain things about scalable revocation we know is coming, but at what time, and just bringing everyone along with us to learn and know these are things. Like for me, the big thing is the ethical implementation, right? Like if you can have all this technology, but you implement it and it gets rid of privacy, or it gets rid of what's the point, right? And you can go and say you're the SSI, you can go and say you're in the SSI community, but and that's why, what ethical framework are we holding people in space to? And especially if you're going to deliver technology into health, that has to be done.
Excellent. I completely agree. So actually, Sonia has asked something, and she just asked it again. So I've got to give Sonia a shout here. Can you clarify about T-cell testing? Do you advocate that as part of mapping immunity?
It's
I have no idea what T-cell testing is.
It's a cellular immune response. So we basically have T cells and B cells, which are part, and B cells come from the bone marrow. T cells come from the thymus, just above the heart. That's why it's called T cells. And they're all different types of particles. It's a cellular, it's more of a memory response. And we have flow cytometry testing, which you can do, but it's a very expensive test. Again, you'll have to see the data because there's 7 billion people. We're all very different. This virus is it's always dynamic. I've said to you it's dynamic, right? So yeah, potentially, but it can change. And how long does that cellular response last? Is it like other coronaviruses where we get it again or not? This is novel. Yeah, so it's, again, I'm not saying I don't know, it's just about learning, right? We don't, and that's the thing. One of the things is, as humans, we just want certainty. We're just in uncertain times.
Yeah, but we haven't got it, have we? Yeah.
And that's the thing, right?
Okay, I hope that clarified it for Sonia. Do you advocate it? Sorry, I mean, let me just ask it again. Yes or no? Do you advocate T-cell testing as part of mapping immunity?
Yeah, I think.
Was it yes, no, or don't know yet?
No, I'd say I don't know. I'd say it's good, but I'd still want to see the data come out in 12 months and have more information and follow people all the way through and see what happens with their response and challenges, right? Yeah. Through exposure to COVID, if they have a T cell or none. That's the studies we need to do. That's how science is based. We don't just say, I don't know, there's large enough randomized control study to do that.
What about, I won't do the Trump thing about the disinfectant. Here's another one from Brad. So Brad's had a few questions, and we're going to run out of time shortly, so we'll probably make this the last one. And there's a bunch of other things we've not had a chance to ask, so thank you to everyone who's been putting questions in. So from Brad, do you think we can get verifiable credentials for practitioner credentials and leverage that for authorization and access and bind consent? Seems like a no-brainer where unpaid college fees could revoke a license to practice, or where, sorry, I shouldn't laugh at that, that's a serious issue, or when sanctions or restrictions are applied to a practitioner by the college. So you've had these discussions with the GMC for having your license to practice revoked as well, haven't you?
Yeah, but we talked about it. So that's one of the things that came out of our pilot in 2019 with the GMC and Blackpool was actually, why don't we create a future where we get a compound proof where if I'm issued my license every day or whatever, or as a push, if that gets revoked, so that's the revocation piece, so important, and every time I log into a clinical system, whether that's a door access or into a electronic health record thing, if I don't have both the one from Blackpool Teaching Hospital and the valid certificate, then I don't get access, which becomes a really patient safety amazing kind of system that we are hopefully putting the infrastructure to lead to go forward.
So I think for Brad, a lot of work's been done on that exact point actually, and the scenario here is that a physician would accumulate multiple credentials from multiple sources for multiple contexts, for different uses in different situations. Okay, should we ask another one? Yeah, okay, we're a few minutes over. We've still got a bunch of attendees on, so anonymous, which is fine. Someone anonymous has asked, privacy respecting webinar. What do we learn from the government's pushed tracing app, Bluetooth-based contact tracing app? Maybe you didn't have any involvement in that anyway, so it's probably unfair to ask.
I had no involvement. I've got my thoughts and opinions, but I mean, all I can say is I'm very privacy focused.
Yeah. And it's a tough gig, that one, right? Trying to get a contact tracing app in place. You can see why, and the tech under the skin is actually pretty good from what I understand about it.
Yeah, I think it's multi-layered, isn't it? It's so complex, and we don't understand it. It's multiple things that it's not in our control. We don't know the ins and outs. That's
yeah. Okay, well, I think with that, Manny, we'll wrap it up. Sorry to those who have asked really good questions. We just haven't had a chance to get to those with the limited time we've got, and Manny's valuable time. So thanks very much for Manny as well. And I think with that, we'll wrap it up. Alex will put the recording of the webinar up on evening.com/webinars probably tomorrow. And look out for the next one, which will be announced on evening.com shortly as well. But with that, Manny, brilliant. I found that hugely powerful. I was getting some messages from other people finding the same thing. Amazing experiences you've had, pretty tough going, and you forgot to mention that you had COVID yourself in the middle of all this really badly. And so I think we all take our hats off to you. Thank you very much.
Thank you for the opportunity to share my story. And yeah, as I said, look, open to work and collaborate, and we can actually really do something special in healthcare if we do it the right way.
Yeah, perfect. Manny, thanks very much. Thank you to everyone who came on and asked a whole bunch of questions, and also those folks at the NHS who've been leading this drive towards digital prevention.
Yeah, echo that as well.
All right, thanks all. That's it for this time. Cheerio.